Welcome to the American Heart Association Statements and Guidelines podcast, where we'll discuss clinical practice guidelines and scientific statements on various cardiovascular disease and stroke topics.
Hello, everyone. I am Salim Virani, and I serve as Vice Provost for Research and Professor of Medicine at the Aga Khan University in Pakistan. I am also a staff cardiologist at the Texas Heart Institute and an adjunct professor at Baylor College of Medicine in Houston, Texas. In my clinical practice, I am a non-invasive cardiologist with a special focus on preventive cardiology.
And I'm Kristin Newby. I'm a professor of medicine in the Division of Cardiology and a faculty member at the Duke Clinical Research Institute at Duke University School of Medicine.
So we are so excited today to be talking about the 2023 American Heart Association and American College of Cardiology guideline for the management of patients with chronic coronary artery disease. Now, I must say at the beginning of this podcast that this is a group effort. In fact, we had a dedicated group of 27 volunteers from various partner organizations, including patient representatives who were part of this effort. And I had the honor of serving as the chair for this particular guideline.
And I served with Dr. Virani as the co-chair of the guidelines, and I'm excited to talk with you today about where we settled on our recommendations.
So as all of you who actually look at the guideline will notice that this guideline provides an evidence-based and patient-centered approach to the management of patients with chronic coronary artery disease. Now, as we'll discuss later, chronic coronary artery disease or chronic coronary disease, CCD, is a major problem, both in terms of scope and severity. And therefore, for clinicians, this guideline is an extremely important guideline to follow in their practice. Now, this guideline aims to provide the clinicians with the best available recommendations on how to address CCD. Now, we'll start from the big picture, talking about concepts in the management of patients with CCD. But then during this podcast, we'll get into the granular details about which drugs and treatments to use in patients with chronic coronary artery disease and in various scenarios.
So we think this guideline will be really valuable for anyone who deals with chronic coronary disease patients. And that is everyone from cardiologists to primary care physicians, nurse practitioners, physician's assistants, even pharmacists and other allied health professionals. So we intend this to be a very broad, very usable, easily accessible document.
Now, the way we have this podcast, we have 3 episodes. So over the next three episodes, we're going to be talking about quite a few things. We'll try to cover a good chunk out of these guidelines. These guidelines, as you will notice, are very extensive just because there's too much to cover when it comes to management of patients with chronic coronary disease. So the first podcast, which is the one that you're listening to right now and watching, we will start out by defining what chronic coronary disease is, what is a general approach to treatment of patients with chronic coronary disease. In the second podcast, we'll talk about concepts in risk assessment of patients with chronic coronary disease, as well as various recommendations that are related to lifestyle therapies. And in the final episode, we'll get into some more details about specific therapies as well as treatments, as well as some special populations that we all need to keep in mind while we're treating patients with chronic coronary disease. Now, Kristin, can you tell us a little bit about how we classify recommendations when it comes to guidelines in general?
Yeah, happy to do that. This is really important before we get into the meat of the guidelines to understand how we classify recommendations. So keep these, as we go through these, keep these classifications in mind because we are going to refer to them throughout these 3 podcasts. So we have 3 main classifications of recommendations. So class 1 recommendations are our strongest recommendations. We have very good confidence that the benefit of what we're recommending outweighs the risk, and they have the strongest evidence, clinical trials, meta-analyses, and observational studies behind them. Class 2 recommendations are a notch below Class 1 recommendations, but they're still fairly strong and are things that are worth considering as we're confronting patients with chronic coronary disease. There are 2 subcategories of Class 2 recommendations. Class 2A is recommendations in which the benefit is still greater than risk, and we think it's reasonable to incorporate it into our treatment for our patients. Class 2B recommendations are a little weaker. The benefit may or may not exceed the risk, or there may be additional risks. So the evidence doesn't necessarily support that we should do that every time, but there are still things that we should keep in mind and consider in certain circumstances. Class 3 recommendations are also very important. Class 3 recommendations are the things that we recommend against doing. And we do that either because they have been shown to cause harm or because there is no benefit. So there are 2 types of Class 3 recommendations, harm or lack of benefit. So these are going to be important as we think about what we're going to tell you here over the coming podcast. So keep these in mind.
Thank you, Kristin. That's extremely important. Now, of course, we need to know what recommendations mean when we talk about a Class 1 recommendation, Class 2A, 2B, and Class 3 recommendations. The other thing that's extremely important is to define what chronic coronary disease means when we're talking about a patient, and what this guideline actually entails and what this guideline does not entail. So this guideline pertains to outpatient management of patients with chronic coronary disease. Now, these patients with chronic coronary disease are defined as patients who are discharged after being admitted for an acute coronary syndrome event, or after revascularization procedure, or after stabilization of all acute cardiovascular issues. So all of these things have to be met. They have to be stable. They have to be in the outpatient setting. The other group of patients who will be classified as CCD, which this guideline will apply to, are patients with left ventricular systolic dysfunction who are known or suspected to have coronary artery disease, or those with established cardiomyopathy where it is deemed to be of ischemic in origin. The third group is patients with stable angina symptoms or ischemic equivalents such as dyspnea or arm pain with exertion, who are medically managed, and they can be managed with or without positive results of an imaging test. We can also have patients with angina symptoms and evidence of coronary vasospasm or microvascular angina. And last but not the least, patients who are diagnosed with chronic coronary disease based solely on the results of a screening study. That could be a stress test, coronary CTA, and then the treating clinician concludes that the patient has a chronic coronary disease. So any of these 5 conditions that I mentioned to you would constitute chronic coronary disease. Now, there are a few nuances here that clinicians should also keep in mind. First, this chronic coronary disease population is a very heterogeneous group. As you can see from the 5 groups of patients I mentioned to you, the risk of future cardiovascular event is not the same. For a patient who has stable angina, the risk is different, much lower compared to a patient who recently was admitted for an acute coronary syndrome, although they're stabilized now. Second, when we talk about treatment of these patients, so of course, we all as clinicians are always thinking about how to improve cardiovascular outcomes, but at the same time, symptom relief and improvement in quality of life are extremely important considerations in these patients. The third important aspect of this is that we believe that a lot of this management for chronic coronary disease can be performed effectively in a primary care setting. So it does not mean that only cardiologists or cardiology clinicians are the ones who should be taking care of patients with chronic coronary disease. The last important point that we acknowledge is that there is a continuum of risk between primary and secondary prevention. The classic clinical scenario that clinicians may be faced with are patients with significant coronary artery calcium that's noted on a cardiac CT or a chest CT, which was performed for any other indication. Now, these patients, of course, have higher risk of having a cardiovascular event compared to our classic primary prevention patients. But these patients, for example, those with high coronary artery calcium score, are covered in the 2018 cholesterol guidelines as well as the 2019 primary prevention guidelines. So we would recommend that clinicians follow those guideline documents when it comes to patients with extensive subclinical atherosclerosis.
So the scope of chronic coronary disease is huge. So it's a big issue for us here in the United States as well as around the world. There are about 20 million Americans who are living with chronic coronary disease. That ranges from, as you heard, documented coronary disease to chronic stable angina that is presumed due to underlying coronary disease. It's a little bit more common in men than women, considering all types of chronic coronary disease. And coronary disease increases with age. But a few comments with respect to race and ethnicity. So we know that white men have higher prevalence of coronary heart disease, myocardial infarction, and angina pectoris than all other race, sex, and ethnicity groups. Black women have a comparable prevalence of angina, not necessarily documented coronary disease, but angina pectoris with that of white men. And Asian women have the lowest prevalence of coronary heart disease, myocardial infarction, and angina pectoris.
Thank you, Kristin, for providing that good overview of epidemiology of coronary disease. Now, when it comes to approach to treatment of patients with a chronic coronary disease, one major area that we wanted to emphasize in this guideline is the overall approach to treatment. Now, of course, from a big picture perspective, the ultimate goal of treatment are three. First is to prolong survival, to reduce symptoms, and improve quality of life. Now, while we're trying to address these three aspects, the other treatment goal also includes that we want to reduce cardiovascular events, whether those are events related to coronary tree or other vascular beds as well. So those are the treatment goals which are beyond just improving symptoms or quality of life, but also improving survival and reducing non-fatal events as well. Now, while we are doing that, it is extremely important that we keep into consideration what are the patient preferences. We all know that coronary disease patients are on a lot of medications, and it's really up to the patient to decide what is important for them. So that preference needs to be at front and center. We need to keep in mind what are the benefits versus risks associated with various treatments as well as procedures, what are possible complications. At the same time, it is extremely important to be very mindful of cost to the individual patient. We know that out of pocket cost is a very important determinant of how adherent our patients are to various therapies that we prescribe, as well as cost to the healthcare system, because we know we live in a system where therapies are expensive and our patients need a lot of therapies. And chronic coronary disease is one such symptom complex. We have other medical conditions that are also, things that we need to take care of. And then last but not the least, how do we leverage the entire CV team? Because as you will see and hear during this podcast, that there are a lot of things that we need to address. And it will be very difficult for just one member of the CV team to address all of these aspects in the management of chronic coronary disease. So with that, I'll pass it over to Kristin. And Kristin, if you can talk a little bit about various other considerations that we should have while we are looking at the overall treatment of these patients, that would be very, very important for us.
So sure, the first step in treatment really is accurate risk assessment. And we're going to talk a fair bit about that, but there are certain categories of things that have not always been highly incorporated into our risk assessment. And those are things like social determinants of health. And there's a large emphasis, as you'll see as we go through this, on assessing and acting on social determinants of health. So things like insurability, health literacy, the environment in which the patient may live. We also want to emphasize engaging the patient. So the patient has to be informed and participating in decision making for our treatments to be implemented and effective for them. And then, as Dr. Virani mentioned, there needs to be a team-based approach where patients and clinicians are working together to navigate treatment of their chronic coronary disease. So what do I mean by a team-based approach? So when we talk about a team-based approach, this is one of the really important kind of critical updates to this guideline. So if we're thinking about treating patients with chronic coronary disease, and we have a class 1 recommendation that the guidelines recommends, we have to consider not only what I, as a cardiologist, might think, but if there is another healthcare provider that's important to application, for example, even the primary care physician and interventional cardiologist, we need to have them engaged. We want everybody's opinion in making these decisions. And then most importantly, the patient is at the center of that approach. So the patient, again, emphasizing patient engagement, that we're thinking about the patient as our primary goal to help them live a longer and healthier life. So the team, as we mentioned earlier, that can be physicians, that can be nurse practitioners, physician assistants. It includes our nurses and nursing assistants, pharmacists, dietitians, the exercise physiologists, as we talk about cardiac rehab. Physical, occupational, or speech therapists may be relevant, and psychologists and social workers. And I would also include in this the patient's family, their nuclear support. That is one of the key social determinants.
And just building on what Dr. Newby just talked about, right? She mentioned one very important message here, which was that patients themselves are an important member of the team. So we need to make sure that patients are front and center when it comes to decision making as well as implementation of these therapies, right? We know from randomized controlled trials as well as systematic reviews with meta-analyses that a patient-centered as well as multidisciplinary team-based approach can improve patient self-efficacy, health-related quality of life, as well as risk factor management. We have quite a few studies where we have a team-based approach. It outperforms approach when it's only one clinician who's taking care of the patient. It's no surprise because there's so many things to cover when we're taking care of patients with chronic coronary disease. So that's one thing. The second is patient education is extremely important because we know, as you will see when we discuss more aspects of this guideline, that social determinants of health are extremely important. We have a lot of lifestyle changes that we recommend. We have a lot of things related to symptom management. Therefore, patient education, and that education does not happen during one visit. It is just an ongoing phenomena that happens on every visit. And it is extremely important to do that education at every visit to ensure that our patients are making informed decisions, both in terms of what is important to them, so we can focus on them, and then it improves their self efficacy to be able to follow what is being recommended. Because we know that adherence to both lifestyle therapies as well as medical therapies is extremely low when it comes to patients with any chronic condition, including patients with chronic coronary disease. And then the other aspect of this is that when we educate our patients, when we put them front and center of every decision making, that is what will lead to shared decision making. Now, whether that is uh, in terms of what therapies to use, what treatment strategy to use. And the end goal of that shared decision making is not receipt of a therapy or a treatment strategy, but it's the quality of that decision that is made between the clinician and the patient. And this becomes extremely important when there is a significant risk with a therapy, or there is a trade-off that exists between the benefit and risk. And that's why it is extremely important to keep patients at front and center. The other aspect of this that I would like to emphasize when it comes to general management principles for patients with chronic coronary disease is to always keep in mind what is the out of pocket cost for our patients whenever we are initiating a new medication or even continuing a medication. And this should be done at every visit. The reason for this is what we discussed earlier, that non-adherence to medical therapy as well as lifestyle is extremely common in these patients, like it is for any chronic disease. So as long as we are talking about out-of-pocket expenses, it will allow us to address one of the most important reasons why our patients may not be able to remain adherent to what we are recommending to them.
So, Salim, just to follow on that, I think we are really emphasizing this team-based care and shared decision-making that includes the patient and their support system. We know that using this approach can really improve, as you said, adherence, but also behavioral changes like dietary interventions, stopping smoking, and weight loss, to name a few. We also know that a team-based approach, when we engage across the spectrum of individuals that contribute to patient care and the patients themselves, we can be more cost effective. We can reduce things like emergency department visits or other unplanned health service utilization and prevent cardiovascular complications, which is our entire goal. So how do we help the patient live that longer, healthier life and do it at a cost that's reasonable not only to the patient, but to the healthcare system?
So these are all very important concepts when we talk about general management principles for patients with coronary disease. Now, one other aspect that you already heard Dr. Newby and I talk about was keeping in mind social determinants of health. Now, these are extremely important determinants to consider in treatment because there's a lot of evidence that they impact cardiovascular outcomes. Now, some of those are probably direct determinants, and some of those are indirect because our patients may not be able to adhere to the recommendations that we are making. Now, these are determinants that are related to healthcare access, economic stability or lack thereof, as well as what is the social context as far as a particular patient is concerned. So you will notice that there's a strong recommendation that these should be routinely assessed by clinicians as well as the care team. And then this should be part of our informed decision making as well. Now, these social determinants of health, in terms of what we should screen for when we are talking to our patients about our recommendations, these include assessment of mental health, mental well-being, psychosocial stressors. Health literacy is part of it. Sociocultural influences, for example, their language, religious affiliation. What is the financial strain that our patient may have, which will, of course, affect out of pocket expenses, transportation related issues, things related to patients' insurance status, barriers or to adherence of a heart healthy lifestyle. For example, issues related to food security. What are things related to neighborhood or environmental exposures, right? Some of these neighborhood related factors are extremely important when we are recommending physical activity. Then what are the social support systems that are available to our patients? So all of these things are extremely important when we are talking about social determinants of health. Now, one other point I would make here is for those clinicians who are watching this podcast is I would refer them to figure 6 of our guideline that actually very nicely lays out a lot of these social determinants that we talked about. But in addition, also talks about what are the strategies that we as clinicians can employ to address those social determinants of health.
So, just to follow on from that, social determinants of health and assessing social determinants of health is so important, but it can also be challenging. So just as one example, we know that the neighborhood environment is important in a number of ways to cardiovascular disease. And one of those is, for example, environmental exposure to air pollution. It's very difficult to counsel a patient regarding environmental exposures because it may not be within their means or feasible for them to change their environment. But we can talk with them about how they can minimize their exposures and include that as part of their treatment plan. And if we don't do this screening, we can't help individuals find the appropriate care teams or community-based resources that are going to be important to them to help minimize their risks from chronic coronary disease.
So thank you, Kristin. So as our listeners would have noticed, what we have done in this particular podcast, the first of three, is to give you an overview of the chronic coronary disease guideline. What this guideline includes. We talked about the class of recommendations. We talked about general approach to treatment, why it is important to make it patient-centered, team-based, why we should look at social determinants of health. We hope that you will find this helpful as you treat these patients. Now, in our second podcast, we will talk about risk stratification. And most importantly, why are lifestyle recommendations so important for patients with chronic coronary disease? We thank you for listening to this first episode. And be sure not to miss the following two to get the full overview of this guideline. So thank you for your time.
Data and statistics presented in this podcast are from the official guideline being released by the American Heart Association. Any and all personal stories and testimonies are that of the talent, host, and volunteers, and are not reflective of any statements or position of the American Heart Association. For a full manuscript of the guideline released, please visit the official American Heart Association website at professional.heart.org.